First of all, I'd like to thanks the organizing team for inviting me for a virtual meet. I'll be talking on weaning and trial of ECMO. I'll be covering both VV and VA ECMO in these 20 minutes of time. What I'm going to discuss is going to discuss the weaning and trial of what is the difference, the indications for weaning and trial of, the criteria for weaning and trial of, what are the weaning protocols and what are the protocols for trial of both for VV and VA ECMO. Weaning is just coming down on ECMO support to bare minimum. So here what you do, you just come down on the flow or decrease the pump flow, decrease the gas flow, decrease the FiO2 in period of hours or days slowly to try to come off from the mechanical supports. While trial of is turning off the ECMO without removing the cannula. So here you don't remove the cannula, you just turn off the ECMO, you disconnect a patient from the ECMO, and that is just a functional disconnection. But still the circuit is running or circuit is on. So what are the criteria or when should we think of weaning the patient from ECMO? First, when the patient starts recovering from underlying disease. Second, when you feel that ECMO is futile ECMO, when you don't expect the recovery to take place. And third, there are situations where patients do respond partly, but there is some condition, desperate condition where continuing ECMO is going to be more harmful. In that case, you think wean the patient from ECMO as early as possible. So when you try to wean the patient, what should be the goal for weaning is there has to be adequate pulmonary recovery. I say adequate, I don't say it's a complete. It's an adequate recovery so that you can manage the patient on a minimum ventilator support or minimum inotropic support. And then you get rid of ECMO so that once they can manage on that, you can come off the ECMO. So what are the indicators of recovery in the lungs? First is improved gas exchange from the native lungs. So whenever the PO2 start going up, the PCO2 start coming down with end tidal volumes, end tidal carbon dioxide goes up. So all that suggests that the lung is contributing from its side. The improved lung compliance, the improved chest radiograph. In case of neonates, the resolution of PPHN, primary pulmonary hypertension, and you can always try to see by doing oxygen challenge test. So what you do in oxygen challenge test is you keeping the ECMO setting same, keeping the ventilator setting same, whatever is going on, you do one ABG. And then you increase the ventilator FiO2 to 100%, rest of the settings are remain the same. And then you repeat ABG after 20 minutes. Now when you do this test, oxygen challenge test, you see the comparison of the two ABG reports, the PO2 levels. If the PO2 initially was say 60, 70, and then it has gone to and jumped to more than 250, that means the lung is recovered enough and we can think of weaning the patient from ECMO. So that will give you a clue that whether you can wean the patient or cannot wean the patient from in the pulmonary ECMO. What are the indicators of recovery from cardiac point of view? One is improved mean arterial pressures. The mean arterial pressures goes to more than 70 in adults patient with inotropes or with minimum inotropes or without inotropes. Improved tissue perfusion, so your venous saturations are going above 70, your lactates are coming down and becoming normal. Your increased pulse counter. So usually when the patient is on ECMO dependent, you usually see in a VA ECMO, you just see the straight line or you don't see the pulse pressure. So the pulse pressure is less than 10. Now, once the pulse pressure starts improving and pulse pressure becomes more than 30, you can think that patient heart is recovering and you can think of patients to be weaned off from the ECMO or VA ECMO. And all this has to be supported by the improving the cardiac functions in terms of echocardiography. And you have to see both systolic as well as diastolic functions, and you have to see both LV and RV functions both. So how will you assess the systolic functions of LV? Is all of you know by doing an ejection fractions. If the ejection fraction is more than 25-30, you can think that a patient can be weaned off from the ECMO. And you have to assess with the diastolic, LV diastolic functions by the help of the mitral. You have to see the systolic velocity at the mitral valve, lateral mitral valve leaflet by TDSA, and by seeing the velocity at the aortic wall by VTI. So these two things also will tell you if the TDSA is more than 6 and VTI is more than 10, then you can think that you can wean the patient off from the ECMO. For right ventricular functions, you have to see the right ventricular ejection fraction, that is most important. And if the right ventricular ejection fraction is more than 24, you can think the patient can be weaned off from the ECMO, and you have to see the TAPC. So in one of the study published by the Journal of American Society of Echocardiography in 2017, they have showed that there is a cutoff level of 24.6 ejection fraction, and they did well and they could be weaned off successfully. And those who have got ejection fraction less than 24, they could not be weaned off successfully. So that is going to be an important factor. Another is when there is a ECMO you feel is a futile ECMO. So what are the cases where you feel the ECMO is futile? ECMO is when you can diagnose this of the irreversible pathology and transplant is not feasible. For an example, like patient is in end stage heart disease or goes into end stage lung disease, patient develop pulmonary fibrosis and the recovery is not possible. So in that case, you think if transplant is not feasible, either it is not available, or if it is the finance is constrained, then you have to think of ending the ECMO. Non-correctable physiology in neonates. In neonates, if you feel that case, some congenital heart disease or some chromosomal anomalies, which is non-correctable, in that case, again, that becomes a futile ECMO, and then you have to think of coming off ECMO. Or in any patient, if the patient develops brain death, then again, it's going to be a futile ECMO, and then you have to think of coming off from the ECMO. But there are certain conditions where patient is improving, you feel that the patient might require few days more, 4, 5 days or 7 days more to come off ECMO, but in between he develops some complications which is going to be difficult to manage, and in this situation risk of continuing ECMO is going to be more dangerous than discontinuing it. And in that condition you have to take a decision, you have to call off the ECMO or wean off the ECMO patient from the ECMO. Like in case of the patient develops some significant bleeding, or they develop intracranial bleeding, or they develop massive GI bleed, or there is a severe hemolysis. So all that can is, or patient is refractory in a sepsis and not improving, and you feel that there's a biofilming in the cannula or in the ECMO circuit, then you can think of take a window of opportunity and try to come off ECMO at this stage, except in the little higher support. Now, what are the weaning parameters for VV and VE ECMO? So when should you, what are the criteria, clinical criteria, where do you think of coming off ECMO? So when the patient, in adult patient, when the patient is on VV ECMO and his ECMO flow is around 3 to 3.5 liters, and with that his PO2 becomes more than 75, saturation is more than 95, and that remains steady for almost more than 24 hours, then you can think that yes, this patient, now you can start coming down on ECMO FiO2. So in that case, you can start coming down on ECMO FiO2. When the EtCO2 level goes more than 35, that means lung is contributing in removing the carbon dioxide, that means lung is improved. Improved lung compliances and radiological improvement, all that things is going to tell you that you can think of weaning the patient from VV ECMO. For VE ECMO, as I told you, first of all, they should maintain the mean artery pressure of 70. Then the pulse pressure has to improve. A pulse pressure is more than 30. You can think of that. The lactates and venous saturations are normalized. And there is, all this has to be supported by echocardiographic evidence in terms of improved LV contractibility, MR, which is either decreased or minimal MR, that the VTI has to be more than 10 centimeter and TDSA has to be more than 6 centimeter. If all these things helps is there, then you can think weaning the patient from VA. In one of the study which is published in the intensive care medicine in 2011 by the Paris team of Dr. Pascal and Dr. Nadia, and they have found that those patients who have been successfully weaned off from ECMO, they have a pulse pressure of almost around more than 40, and those who have weaned off, they have a pulse pressure of more than 40, they have aortic velocity more than 10, they have ejection fraction more than 25, and they have TDSA more than 6. They are the one who could be weaned off easily. Those who have ejection fractions and VTI and TDSA less than this, they could not be weaned off successfully. So what should be the weaning algorithm? First, in first 72 hours, there should not be any efforts to wean the patient from ECMO, except in case of poisoning, which can improve faster. But otherwise, myocarditis or usual our case is ischemic cardiomyopathy and cardiogenic shock. They usually take a longer time, so that you should not give an attempt to this. And before going to that attempt, hepatic and renal functions and other metabolic disorders should get stabilized or stabilized. So first step is whether you have to find out whether the etiology, underlying etiology is compatible with myocardial recovery. If yes, then you have to see the hemodynamic stability. If the hemodynamic stability is there, metabolic factors have been corrected, then you can think that yes, you can think of weaning the patient from ECMO. You have to see the pulmonary functions. If the pulmonary functions are improved, fine, you can think of weaning the patient. If pulmonary functions are not improved, but cardiac functions improved, then in that case, you might have to switch over patient from VA ECMO to VV ECMO. And then after giving a full weaning trial, if patient maintains hemodynamics, he maintains all parameters of monitoring, then in that case, and with the minimum flow of 1 to 1.5 liters, then in that case, you can think the patient can be given a trial of, and then the patient goes to trial of, and after that, if the trial follows successful, then you can think of doing decannulation. So VA ECMO, how will you do it? The methodology, you have to decrease the blood flow by 20 ml per kg per minute till you get the ideal flow. The ideal flow is the minimum flow, that is 20 ml per kg per minute. That's the minimum flow. So in adult patient, if your patient on VA ECMO, if you come down gradually to a flow of around 1 liter per minute, in that case, you feel that case, that is a minimal flow. And if we maintains on that, then you can think of going the patient for trial off. So you have to gradually come down from flow, whatever is around 4 liters or 3 liters, gradually come down that flow by decreasing the flow every 3 hourly to 1 liter per minute. So this is what a full VA ECMO, whether and the most of the blood is going to the ECMO circuit, while very minimum blood going to the patient. And then when you wean the patient, the minimum blood is going to the ECMO circuit, while the maximum blood is going to the patient circuit or patient circulation. This is little different in case of VV ECMO. In VV ECMO, you need not have to change the blood flow. Whatever the blood flow might be 3 liters, 3.5 liters, you can accept that blood flow, let it remain like that. But what you need to do is you have to just reduce the FiO2 first, and then you have to reduce the sweep gas. And by reducing the FiO2 and sweep gas, you can wean the patient from VV ECMO. You have to go up on the ventilator settings when you are coming down ECMO FiO2. Once you are less than ECMO FiO2 of 50%, you have to go up on the ventilator settings and a bit, and then go further down on ECMO FiO2. Once you are on ECMO FiO2 21%, then you can start reducing the sweep gas also. There are some people who don't reduce the FiO2, they just directly go by reducing the sweep gas also. That is another method of weaning the patient from VV ECMO. So what usually ventilator settings we prefer to do it is we try to get the patient out with a moderate ventilator settings. So FiO2 of around 40%, PEEP of around 8 to 10, peak pressures should be restricted to 26, and respiratory rate we accept anywhere between 20 to 30. So that is the settings what usually we prefer to come down on ECMO. But again, that will vary from patient to patient. The patient has got pneumothorax, we'll try to keep the PEEP on lower side definitely. If the patient, if you are looking into a rush kind of weaning or in a desperate situation, we'll even accept the FiO2 of 60% and try to come off the ECMO with that stage. So this is what the physiology of ECMO, VV ECMO. Usually, what are the blood goes to the lungs, does not get oxygenated, and it comes on the same way. And when the lung improves, the blood gets oxygenated in the lungs. So what are the monitoring things which we are going to do it? One is gas exchange, that is PO2 levels, PCO2 levels, and pH of the patient. The second thing, the most important is tissue perfusion, especially in case of VA ECMO. So you have to keep a watch on venous saturation and lactate levels, and hemodynamic response, the heart rate with the patient developing tachycardia while you are coming off ECMO or you are weaning the ECMO. That is not a good sign. Patient BP fluctuating, that is not a good sign. Sorry. And then the most important way for a VA ECMO, you have to look into how the heart behaves or a cardiac function behaves when you try to wean off. At different stage of weaning, you have to always monitor that. How is the LV and RV systolic functions, whether the mitral regurgitation which is there, is it increasing or it is decreasing, whether the chamber size is getting dilated. If the chamber is getting dilated, then that is not a good sign. In that case, you have to stop weaning from that stage and you have to go back on the full support. You have to look at the VTI, the TDSA, and the TAPSI score to see the RV and LV functions. And this is one of the same study by the Paris team. They have found that those patients, when you start weaning them for a VA ECMO, and when the ECMO flows 100%, and then you start weaning them, if the ejection fraction keeps on going up, improving, if the TDSA improves, then in that case, they usually do well and they can be weaned off. But in those patients, even when you come weaning, once you start weaning and the ejection fraction and the TDSA remains the same, then usually they don't do well and they cannot be weaned off easily. Now next is trial off. When to trial off for VV ECMO? So when you are successfully able to wean the patient, when you come down on ECMO effort of 21%, when you are able to come down on sweep gas, and eventually after that also you are getting good blood gases, tissue performance is fine, hemodynamics are fine, and moderate ventilator settings only moderate. In that case, you can think that yes, patient is doing well, and you can think of getting the patient off ECMO. That is, you can give a trial off. In VA ECMO, again, when you have come down on flow of 1 liter, and in spite of that 1 liter of flow, patient maintains good hemodynamics, tissue performance is fine, and that too with the minimum support of ECMO, minimum inotropic supports, and minimum ventilator supports, you feel that cardiac function has come down to baseline, and then you can think of getting the patient off ECMO. But before you give a trial off, you have to keep 3 things in your mind. First, whether there's any risk of continuing ECLS for another few hours or few days. Second, whether of risk of coming off ECLS, at what support you want to come off, and whether it is going to be safe support, and degree of support you have to decide how much support you want to give to the patient. So what is the methodology? The methodology and the duration of trial off depends on the type of ECMO, whether VA ECMO and VV ECMO. VV ECMO, we can give trial off for a longer period of time. In VA ECMO, we cannot give trial off for a longer period of time. We have to restrict ourselves for only 1 to 3 hours. While in VV ECMO, you can wait for 8 to 24 hours or so for a trial off. So VV ECMO, the methodology is very simple. You have to just do a capping of the gas. So what you have to remove, you have to just, whatever the oxygen you are connected to the oxygenator, you have to just remove that. And so that means that there is no ventilation or there is no gas exchange taking place at all from the circuit. The blood, whatever is coming in the circuit, is going back the same way what it was. So you just pull the green tube from the oxygenator. Blood gases, you have to do it at the 30 minutes of interval after 2 hours and then after 6 hours. With the adjust the ventilator parameters as per the blood gases, and see to it you don't go on higher ventilator support, just accept the moderate ventilator supports. Okay, so this is the way, whatever the blood we are going inside, the same blood is coming outside. So there is no gas exchange taking place in the circuit here. Whatever gas exchange takes place, that is through the lungs only. So trial of for over 24 hours is also possible if gases are borderline. If you are not very comfortable at the end of 8 hours, you find that still patient is on borderline, you can continue this trial of for 24 hours because you are not decreasing the flow. So there is no increased risk of clot or bleed, clotting in the circuit. So you can continue this trial of for 24 hours. Minimum trial of has to be at least 4 hours. And if suppose something goes wrong, if you find that patient is deteriorating, you can just connect the green line, pipeline, and that's fine. The ECMO is already started. And then once you restarted ECMO, wait for 24 to 48 hours to give another trial off after that. Now for VA ECMO, there are 2 methods of VA for trial off. One is traditional method and second is a pump control retrograde trial off. In traditional method, what we do is we just clamp the cannula, we just clamp the cannulas and we open the bridge completely. The patient and circuits, both are isolated from each other. They are not functionally, they are not connected to each other now. And every 10 minutes, we just release the clamp for a few seconds so that whatever the blood is accumulated in the cannula, it goes back to the patient. So patient is connected every 10 minutes to the circuit only for a few seconds. Otherwise, patient is off that. We have to do ACT every 30 minutes. You have to target ACT on higher side because this patient, we are clamping the circuit, clamping the cannulas, but circuit is on. But the circuit is on. So, and this trial off should not be more than 1 to 3 hours. You have to give heparin both to the patient and circuits, and ventilator settings should be moderate if required. While in pump control retrograde trial of what you are going to do is you are going to decrease the, see, as you know, this is a centrifugal pump. So what, when we patient is on full on ECMO, what we do is patient on with RPM of 3000, his flow is around 2.5 liters. So this is this is what the blood is coming out and the blood is going, this is a venous blood coming out and the arterial blood is going back. Now what you do, you keep come down on RPM. So when you come down on RPM, there is a retrograde flow will start. So you have to see that retrograde flow that starts, so you have to reverse the flow probe. The retrograde flow should be around more than 500 to 1 liter of flow. So the flow is now in this direction from artery, it goes back to the vein. So what is the importance of this is, you have the sweep gas to FR to 21%, you have switch off the sweep gas, you are not doing any gas exchange here. So what is the importance of this? This is giving you a good RV feeling. And because the RV feeling is good, venous return is good, and that will give increase the preload on the left ventricle, and thereby you will able to assess the left ventricle and right ventricular functions both. So pump speed you gradually decrease. Because there's a central pump there, it will act as a resistor. So there is no free atriovenous fistula. Retrograde flow ensures RV feeling and good RV function that can be accessed. And sweep gas, as I told you, you turn off the sweep gas completely. Now, only thing that there's a disturbed oxygen cannula, so you disconnect the disturbed oxygen cannula, you keep on giving some 3 ml per hour of fluid to the disturbed oxygen cannula so that it does not get blocked. You have to give heparin bolus. Again, you have to keep the ACT on higher side to around 220 to 250 and give heparin bolus as for what is required. Monitor the hemodynamics, monitor the echocardiography, and at the end of 1 hour, if the all parameters are fine, you can think the patient to be weaned off from the, to be taken off from the ECMO, and you can think of plan to decannulate this patient. So VA ECMO trial of is monitoring. As I told you, you have to take ABG, venous saturation, lactate every 30 minutes, 90 minutes, and 1 hour at 1 hour and 80 minutes. At 180 minutes or 1.5 hours. And you have to do the echo at the interval of 1 hour and 3 hours to see what is the LV size, ejection fractions, mitral regurgitation, VTI, and TDS. And as I told you, if you find that even the echo parameters are worsening, then you have to stop trial of there. You have to go back on the ECMO full support and wait till the time the patient, wait for 24 to 48 to give another trial of. So in just the last slides, the trial of VV versus VECMO. VV-ECMO, yes, you have to switch off the sweep gas, but in VE-ECMO, you have to appearance the patient, define the circuit, clamp off and clamp on, switch off to sweep gas has to be off, you have to flash the cannula, and you have to go for a surgical decannulation. Any questions? I'll love to answer. Thank you.